This Wednesday, the 27th of,
50-some pages.
okay. Okay, are there any changes to the agenda?
Yes.
Tim?
We had number 4, which was the employee retention credit. I'm going to pull the contract on that. Primarily, I just sent it off to Scott to take a look at, and I just got it back this morning with significant changes. So I need to go over those with David and so forth. I don't think it's anything that's going to change us from doing it, but we're going to have to get back with them and see if they agree to the changes and so forth that he's asking for.
Okay, so we're going to pull, what is it we're pulling?
We're pulling number 4 off of new business.
Okay. Heidi, did you get that?
I did.
Okay. Okay, then the next thing is approval of the minutes from the last meeting, June 29th.
I didn't see any concerns, so I can make a motion.
Okay,
That
you don't
we
need to make
accept
a
them.
motion. As long as nobody objects to them.
Okay.
then they're approved.
I will second that. So
Okay. Then, is there anyone from the public who wants to make a comment? Nope, hearing none. And then we'll move to financial statement. The one that probably knows more than most of us. Well, almost more than me, Dave.
Thank you, Gene. So we're going to jump right in,
Yep, please.
and I think it's right here. Okay, can you see that?
Man, that's too big.
Oh,
It's a
okay,
lot
we'll
of
make it a
money.
little smaller here.
No, that's
Page-
great.
No,
No,
it was fine.
it's great. It was
Page
great.
8.
zoom
Is-
back out again.
We'll zoom
Yeah.
back out again. Oh,
One, there you go. Perfect.
Perfect.
So we're going to start talking about, so we're done with the fiscal year. It's also be a year-end report. We're going to talk specifically about the month of June. Line item 8 was significantly lower. Acute days, we had a very slow inpatient acute. You can see that 60 compared to the budget of 119. Similarly, if you go down to line 20, you see that the average daily census in acute was only 2.0, which is about half of the normal occupancy that we normally receive. So that was an unusually slower month on the inpatient acute side. The other item that I want to make reference to is an error on a line item that was missed, 36 observation bed days. That number should be 13 for the month, and then for the year that number should be 131. So we need to figure out what's going on, why those aren't always getting updated like they should.
Dave, I'm before, didn't we have the census for the skilled nursing or we're out of skilled nursing?
Well, we can look at that number. That's line.
Oh, average day. Okay, I'm sorry. I'm looking at it.
Yep. You can see the resident days were down. The average daily census for long-term was also lower, 46.3 compared to the 52.4. I believe we're up to 48 now in the early July, so it is starting to come back.
Yeah, she told me yesterday she's got 3 more that she's looking to move in there right now. So I guess up over 50.
Great. The only other thing I wanted to point out on statistics today was we're still looking at this retail pharmacy scripts. We believe this might be slightly understated based on how the new way that we're billing Medicare, and because the revenues so far haven't not dropped off like we thought.
What's happening there, David, is that beginning January 1st, when the state took over the pharmaceuticals for the Medi-Cal patients and so forth, they have been promoting 90-day scripts instead of 30 days. And so our pharmacy has been doing that. So while they're not filling as many scripts, they're actually filling the same number over that time period. And so that's why the revenue is not dropping off what the number is. So we
Okay,
may need to go back and just relook at this as to how that reports out over time.
yeah, so we'll keep a close eye on that. What I can report is for the year, retail pharmacy revenues are up 4.6% over budget. So I don't want any of this committee to be misled that we're necessarily underperforming in that area.
Yeah.
So we're gonna move on to 2 pages up. And we're gonna look at a number that's, I believe, the highest it's been ever. We're now in what we call excellent category, greater than 3.77 adjusted financial strength index. Most of that is due to the fact that some of those ratios are dependent on a 13-month rollover trend. Well, the only bad month we had was 14 months ago, and that dropped off. So we have an excellent total surplus profit margin besides the higher cash and the other financial indicators that show us in an excellent rating. So we can feel good about the fact that this number continues to climb higher. We finished the year, bottom line on the next page, the next graph below, net income $4,446,000. And you can see how that compares favorably to the last 3 years and also to budget. I'll make one comment. We had a low bar this year. Chet's budget was only $727,000. I just want to remind this committee that we really increased the bar significantly. Next year, the budget's $3.9 million. So it'll be a lot harder to hit budget next year, partly because we set a higher bar. Now, one of the reasons, go ahead.
You're putting what is in the net income? Does that include our easy money?
Yeah, some of the easy money's in there for next year that Chet didn't put any of that in there in prior years. So I don't know if what you call easy money. It's the money that we haven't had to pay back that we receive. Right. I mean, the reality of it is a lot of that COVID money did result in higher expenses. So we are legitimately recouping things that we had higher expenses on.
It'll take us a while to get adjusted, probably till next year before things start to get a clear picture. But if we keep getting COVID and the world changes to where people don't want to go to see their doctor because it's so contagious, it's going to be a different world.
It doesn't look like it's going away overnight. That's for sure. It looks like at least for the next year, it is going to be ongoing. The same kind of new dynamics occurring with how we're dealing with financial revenues and expenses on the ER
and dealing face to face with our patients. It's gonna be a different world because that virus, and I hear there's other viruses coming around, and so we need to keep an eye on how we operate. But at any rate, Dave, sorry.
So far, so good. This organization has benefited from how the rules have been configured to help out critical access hospitals. The next graph here is, if you just look at the trend of the 3 years of ER visits, down, 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 and then look at the actual for this year. So we went up quite a bit from the 6,000 up to 7,153 in ER, which is a nice growth number. On the next graph, we ended up kind of limping into the end of the year. Acute days was higher most of the year. It actually finished 2 days higher than it was the year before, 1463 compared to 1461, but it did go up slightly compared to the prior fiscal year. We all know about the swing skilled nursing trend there, going down from 18,086 down to slightly under 17,000. The next item I have in my notes is the overall bottom line on this positive takeaway. So we beat budget by 3.7 million. Although 2 million of that was from prior year, and actually another million from another category was also considered. But there was at least 1.1 to 1.5 million of legitimate bottom line, which does exceed budget. So we had a good year. We beat budget, albeit not as a aggressive high dollar amount in the budget, 727,000, but we beat budget. We also had the benefit of being able to post some prior adjustments.
Can I ask Tim a question, since, and we are doing good, and you're a big part of it. Tim, would it be legal for us to give him a 10% bonus of what I make?
Sure, it would.
How about 20%?
Of what you make here, let me put it.
What you
that way.
Yeah, that's what,
Let me clarify, it's what you make here.
What I make as a board
And
member.
you know what? I still consider my role as I'm just reporting the numbers. A lot of what you see in terms of positives was a result of how this organization's been run over the years, and I get to be the benefactor of giving you the good news.
Okay, then 5% of what I make as a board member.
The one item on the negative side that we knew it would happen is when you look at where we started the year with cash all sources, 29,432,000. We did fall off about 4 million. Now keep in mind, IGTs was about 2.3 million, less than what it normally is.
Mhm.
The other thing that is happening right now, and it's going to continue to happen, is we are obviously going to be spending more and more on construction and the master projects. So anytime you're spending the kind of dollars that we're going to be spending without using borrowed money, you're typically going to see a negative cash flow there. And in this case, it was $4 million for the current fiscal year. We are budgeted next year to go down like 1.2 million, continue to use some of our liquidity to keep moving forward on the master project.
So that 4 million, was that mostly just money we didn't get to keep, or we had to not get paid through Medical because
It
of
was
advances?
a lot of it was IGT. The other is just a byproduct of, as you get deeper and deeper into these construction projects, we're using a lot of cash. We're going to be burning through a lot of cash, and that's what we knew that ahead of time. And we're just taking advantage of the fact that we have this liquidity that we can continue to move forward.
Dave, do we have any idea what what we're expecting IGT wise coming this year? Because I know we all knew last year was going to be a short year because of the change of the year end date. But the expectation is that we would see that pop back up in the next year.
If you don't mind, I actually have a slide. I was going to show you that number in a couple slides up.
You got it, no problem.
The next line item, we're going to move up to the liabilities page, which is page 13, I believe, or wait a minute. Let's see, 12, okay. Because there's a remarkably low number here. When you talk about liabilities, you want the lower the better. And you can see number one, accounts payable. I'm pretty confident this is probably as low as it's ever been. We're down below $1 million, 938,000 in terms of trade debt payables. So Barbara has really taken it seriously that when invoices come in, she processes it very efficiently. And we have to say there can't be too many creditors out there that are too unhappy with how fast they're getting paid. So 938,000, you can see a year ago it was 1.8 million.
Oh, Barbara, great job.
and she's on vacation this week, so we'll tell
Oh,
her when
well,
she
I
comes
think
back.
she heard me because she's probably at home.
So we're gonna go into the current month financial statement. And you can recall, we were talking about how slow inpatient acute was. Sure enough, line one on the gross revenue for the month of June, 44% below budget. So you could see similarly, as census was half of what we normally budgeted. We also, the revenues were similarly about half on the inpatient acute side. So that hurt us when we look at the grand total revenues. We finished the month 5.7% below budget. And it kind of was the main reason throughout the whole financial picture for the month of June. Everything was a little bit down because our revenues and our acute side was down.
Why was inpatient half as much? Mark, is Mark there or Tim?
Well, I know we had a lot of ER volume coming in, but very little of it actually was admittable. And so we've seen that reverse itself in July. We're actually ahead of budget in July.
Yeah, July is busier, yep.
Yeah.
It was just happened.
Yep.
And those things are fairly frequent where you really can't put a finger on exactly why, when it goes up, why it goes up, and when it goes down.
Yeah, that was pretty significant though, from what I've seen over 13 years. So.
Okay, thank you.
So we ended up a little bit below budget for the month, a slight loss of 70,000 operating loss. The really good news is we got some big COVID money in that we weren't expecting. We didn't put it all to the bottom line, but 938,000 shows up on line 30 as investment income. That's all non-operating revenue. So for the month, instead of being below budget like we were from operations, we finished almost 800,000 above budget because of that high COVID payment that we got to post for the month of June. So moving on to the year-to-date picture. We have a situation where if we were to kind of characterize this year on the volume side, all you have to do is look at the percent variance to budget on line 6, and we're within 1%. So we pretty much was about as busy as we had budgeted, very close to budgeted volumes for the whole year, 0.7% higher on the gross revenues side. What helped us get above budget was the fact that deductions from revenue were less, so we ended up $1 million better than budget on line 13. Now, the reason why deductions become less is for a couple reasons. One was the prior year adjustments. The other was a higher amount of IGT money. That this is getting back to Tim's question. So Tim asked us, what do we expect for next year? And how does that compare to what's currently happening? Well, we finished this year, line 39, at 9,058,000 of the receipts, gross receipts that came in. This does not include the amount we have to pay for matching. So that's not a bottom line impact. Bottom line impact is more like 6 or 7 million. But it was higher than what we expected by about 300,000. So we not only, even though we had a lot less than we had in prior years, the 13 million, we did get more than what we had budgeted. Similarly, we have a more optimistic picture going into this current fiscal year. This projected IGT number is about 2.4 million higher than the 9 million that is, and it's really going to be important for me personally to see that come to fruition, because I'm basing it on a lot of notes and comments that I see from what Chet made and all of his calculations. Some of it has to do with whether or not monies that used to go to Tehachapi from HealthNet ends up coming our way We don't have any 100% assurance yet of that happening, but we don't have any reason to think we're not going to get it. But that would, if it all comes through, it should be about 2.5 million higher than it was this year on the IGT picture. So, and then going forward, we don't have any reason to think that subsequent years would be, you know, the type of fall off that we had the year just completed.
Dave, Chet used to be able to look at the mechanics of that every once in a while and orchestrate a few things that made us get more. Are you inside the inner workings of that IGT? You know what I'm talking about.
Yeah, and a lot of it is relationship building and making sure they know we're out there and that we need help, and staying in touch with the people making those decisions on how to allocate the money. Another is having a good CEO that found out about this program that I was not aware of, that's related to the employee retention credit.
You hear it on the radio every 5 minutes. So you think that we would all think about it. It just don't make sense that they would give it to us because we're doing pretty good. However, he did a good job in finding it.
He did, and I have some big shoes that I have to continue to fill, and it's a very important role that he played. So moving on to what I want to do on the next 2 pages is kind of trend out, if you kind of think in your mind how this year evolved. I'm going to go back 2 pages, which starts the beginning of the fiscal year, and we're just going to look at the revenue side, which is the top part. So we're starting in July of last year, the very first month of the fiscal year that just ended. You can see we had 10,805,000 in gross revenue on line 6. Then if you work backwards, every month since then, we started to see a decline. By the end of December, that number went down to 9.2. And then you go to the most recent 6 months, 9,788, 9,799, 96, and then 89. So we kind of limped into the end of and we came in like a lion and out like a lamb, I guess is one of the phrases. In terms of the revenues and the volumes, a lot of the success we had on that part happened earlier in the fiscal year. So hopefully we can turn that around. It may be a little bit of a rocky road this year. We have some new contracts that Tim has to work out with physicians. We have a number of challenges that have to be solved in order to get our revenues back up to where they need to be. But just kind of give you a picture that yes, we had a really good year and we beat budget by 3.7 million, but we kind of limped into the end of the year as it relates to the revenue side.
I should know this, Tim, but the retail pharmacy versus the in-hospital pharmacy, where does the inpatient, when they're sort of tied together in a way, but they're not in a way?
That's correct. They're totally separate, right? They're licensed separately.
Okay, so the income for the inpatient pharmacy or the in-hospital pharmacy, where is that showing up, Dave?
The inpatient pharmacy shows up on the inpatient revenue, that very top line on the gross charges. So that does not include retail pharmacy. It's just considered inpatient acute revenues, like all the other departments, like CT scan or anything else that an inpatient would receive services on.
Are they tied together in any way, like discounts or?
No, the way we get paid really is not so much a function of what department it comes from as it is an overall contract based on other issues other than the department that provides the service.
I mean, purchasing is what I was referring to.
Yeah, the contracts are more complex than that. All I can say is there's not an easy way to explain to convert charges to payment, except to say that we're a critical access hospital and we do benefit. And when we have patients who are Medicare, straight Medicare, this formula is that it takes about 2 years to get updated on our costs, and we will have an adjustment based on our costs. So if our costs go way up, we are covered, at least through the Medicare population, that will receive a similar percentage increase with all this hyperinflation. Problem being that we're seeing a higher and higher percentage of seniors who are now choosing to go to a Medicare Advantage program. So we don't get quite as much credit as we used to when it was mostly 100% of the seniors had the straight Medicare. So we don't get quite as much benefit on the cost basis that we used to get. So I'm going to jump on to this AR page 12, and we have some favorable trending going on. We saw the line item 16, the total gross AR. In May, it was 31,420,000. That number dropped dramatically down 3.5 million to 27,922,000. Similarly, the gross days fell from 99 down to 91. So we finished this year slightly higher than where we ended last year at 86 to 91. We have 79 in the budget. We eventually need to get back down to 60. I'm still working on some consulting, so it might cost us some money to help improve the overall operations of the business office with some better training. So that might cost us a little bit of money to get us back to where we need to be, where the yellow numbers are here in the mid to 70s or even lower. But we do have some good news in the current trend. They are starting to work out some of the bugs and making some improvements. The last thing I wanted to point out is just a line item that shows up on our cash flow that was a pleasant surprise. So if you go to the very last page, page 15.
Page 21 in your packet.
Right. So I color coded this hot pink because it was a nice, pleasant surprise. When we got the 427,000 for COVID stimulus last month, I was thrilled because that's what we submitted in November. What I didn't know is there was another check right on the back end of that that came in a week or two later for 1,169,000. So we ended up getting almost 1.7, a little over 1.7 million of new COVID money. And you can see how that compares to what we had received in prior years. So we're probably
extension 335.
we're probably close to 10 million now in total stimulus funds, and obvious part of my job is to making sure we don't have to pay any of that back. So, but that really helped us financially getting that amount, and it wasn't something that automatically came to us. We did have a lot of forms to fill out. We had to do it in the right way that we qualified for the highest amount possible, and we do use consultants for that. And there's an individual from Whipfley, West, who was very helpful, sending me spreadsheets and ideas on how I could separate out costs and revenues so that we show that there was revenues lost as a result of COVID and that there were higher expenses. So we continue to have that to be a priority, which is something unique for a hospital CFO, that we have this type of major dollars that are impacted one way or the other based on our success or failure of being able to recoup and collect new monies that the federal government's making available. I was going to spend time transitioning this into talking about but we tabled the agenda item for the employee retention credit, which is another example of us taking advantage of these programs. But that's my report for the month of June.
Dave, when we're looking at that retention credit, it's because as a whole, our operation was able to keep our employees. It wasn't, I'm not saying they don't deserve some money, they do. However, I don't think that money was intended to give to
No,
the,
No, it doesn't have to be given to it. But however, we're still going to be affected by other hospitals who are starting to pay their people a lot more than they used to.
I understand, but what I was just want to get clear in my mind that
Yeah, no, it's not a
There's
necessary
other
thing that the money that comes to the hospital should go right to the employees. We'd like the employees to think that they're important to us and that they're near the top of our list.
yeah,
in
they
most
are,
cases.
they're absolutely awesome, every one of them.
And we don't want to, especially the good ones that have been here a long time. We don't want to lose any of those good employees. And one way you can look at it with some type of retention, lump sum bonus opportunity. And as soon as we know more specifics, we're going to be presenting something. We don't want too much time to pass where the employees can see that we're responding in a timely way to understanding what they're having to deal with on a day-to-day basis with their own personal finances.
But as far as the distribution, is there going to be a meeting about how we think we want to do it?
Yeah, I have some very specific opinions that Tim wants me to keep quiet until we have a better way of discussing it.
Well, this is one simple way to look at it.
Yeah,
The individuals, regardless of how much they make, are all affected the same. They go to the grocery store, they all pay the same amount more.
Yep.
They pay for gas, they all pay the same amount. The higher paid doesn't pay more. So I think a flat amount for each employee. Now that's, I want to be able to get that idea into
Okay.
the heads because it
Yeah.
would be fair to everybody.
that point well taken. To be honest with you, that wasn't my first approach, but it makes a whole lot of sense to think that way.
Okay, thank you. That was nice. You're the first person that's ever agreed with me, at least this month.
Well, I'm kind of agreeing with you,
Oh,
although
okay.
I think the advanced nurse in med surge that makes a little bit more money should also be rewarded.
Well, but what we're giving it for is because of the hard times right now. But at any rate, we're not talking about that.
We can't afford to lose those really high paid people is my point.
I will say that there are forces at work in our very own community that are trying to woo those nurses away right now as we speak.
So I don't want to fool around with the people that really make the most difference, that have the qualifications that can make or break the patient's outcome. And those people we have to honor, even though they might make a little bit more money.
Okay, well, are we going to have a discussion about that or before you present it for approval?
I don't know. Tim's the CEO. He's got to decide how to
Okay, Tim.
sort
Yeah,
this
no,
all out.
obviously I want as much feedback on that as possible. Again, this is
Well,
a good size chunk of money if we get what we think we're going to get. And I want to make sure we put it to its best use.
and the board should have a say in it, not what you put out here and say, hey, approve it or don't approve it. We
No.
should at least have a discussion there.
Oh, absolutely. I want everybody's input.
Okay, thanks for your report. Okay, now who's doing Barbara's report?
We were going to go through any specific questions
Okay,
that you
Yeah.
might have, but if you want to go through each line item and see if you have any questions as we go down the list there of contracts. Heidi, do you want to present that?
I mean, if anybody has any specific questions about the local vendors or the contract reviews, we can try to answer those for you.
okay, the one 18,000 gallon tank, what is that?
That's the big giant propane tank out front here
But what,
by the conference room.
but what is it? What's it saying? What are we doing with it?
Is this on the contracts list?
This is Kern River Propane. This is just the
Yeah.
contract with them.
Is that used? I think it's used as a generator. I think the propane is used as a generator in emergencies. That large tank outside.
Right?
Yeah.
Okay, is it listed on there specifically what they're talking about?
This is the contract with Kern River Propane.
Okay,
It's just, again, that contract really was for the big tank. That's all. That's all that means.
okay, but has it been a year already?
Must
it-
have been. I mean,
Well,
it's not technically due until October,
he
so,
sends these out 90 days in advance. So in October, it'll be a year.
yeah.
Okay, so everything is just the way it was,
Yeah.
basically.
Yep.
Okay,
It's just an annual review.
okay, good. I mean, we need to review it. All right, thank you. And I've got no question, anything else? Catherine?
Hey, Tim, I looked at that AMN healthcare one too, and that's not the one I was thinking it was.
Okay,
That one we need to go ahead and renew.
okay.
No, I don't have any questions, Jean, or anything.
Okay, all right, then that's okay. Then I guess we'll go down to capital expenditure request. Familiar face, Carrie.
Hello, how are you?
Good morning.
Okay, so
Thanks,
this,
Uda.
this is for a new service. It's a budgeted service. I put it in my budget for this fiscal year. What this is it's called the MTR's Managed Threat Response. And so we already have a relationship with this company. Sophos, who's the company I would choose for this. A real high level of what it does is it's 24/7 network monitoring and endpoint, meaning PC, and server monitoring for all malicious activity. Now we have lots of safeguards in place, but stuff can still get in. And a big threat to healthcare is ransomware. I mean, there's lots of other threats, but ransomware, 59% of all ransomware incidents in the US in 2021 were in healthcare. So obviously the vast majority, there's lots of other sectors out there, healthcare got hit with 59% of it. So we are by no means immune to this just because we're small. If anything, I would say that we are possibly more of a risk because we're small and we don't necessarily have the means that some big healthcare organization has. So we need to protect ourselves just the same. And so this greatly assists us in doing this for a few reasons. Right now, we have our IT team. We work 40 hours a week, Monday through Friday. That is when we work. So ideally, if I was somebody doing something malicious, I would attempt to do that for off hours. So, you know, sometime over the weekend or in the middle of the night, something like that. This is 24/7 monitoring, so it's going on continuously.
Is that the one that says $36,000 and change?
$6,000. I don't think any of them say $36,000. There's a $45,000 one and a $65,000 one.
Okay, so that must be the pharmacy.
That might be the farm. That's the pharmacy one.
Yeah, sorry. I'm just going through order. I think I was up, wasn't I?
Yeah,
Okay.
page 24.
Sorry, wasn't trying to jump ahead, but okay. Anyway, so this is, like I said, 24/7 monitoring, and we don't have the talent pool to pull from like a big city that we could get some security engineer to work for us. We are small, and our team reflects that, and so we don't have these engineering and network security level folk that are going to be able to help us respond or identify or help mitigate something if something were to happen. And so this would be a team of those type of professionals that are reviewing this in the event that there was something malicious going on.
Do we do anything with like UCLA or any of the big medical schools that sort of like us to be able to survive? I mean, they have so much money and power into what they're doing. Do we ever get advice? Not Carrie, no disrespect for you. I have every bit of confidence. However, do we ever get advice from some larger company like them?
Have I ever reached out to an organization the size of UCLA for advice on how we should do things here? No, I have never done that.
Okay.
But I do reach out to,
Tim, don't they like to help rural hospitals in different ways?
Yeah, not so much in the IT side. They're looking more clinical things, applications, stuff like that.
Well, our IT side's getting pretty expensive.
Oh, no, there's no question about it. No question about it. It's, this is something that I think that every hospital in business is actually having to deal with. And like I said, I think, from what I've been seeing when I've been here, I think we've done a much better job than a lot of the other small hospitals because of our relationship with CPSI and the risk assessments that we do, trying to close every one of those windows and doors to prevent people from getting in. But even with that, that's still considered basic coverage and so forth. So these services like these are really necessary to help plug those holes and to just keep a set of eyes on the problem at all times. So,
well, right now we can afford it, but however, we're digging ourselves into a big hole. Dave, you were going to give me some type of budget or spelled out a little breakdown better than what we've got.
Yep.
What we've got is a big budget for them, and it was in the budget, but
Yes, I'm about halfway through that report, and I hope to have that for you. I could do it at the full board meeting, or we could wait till next month.
okay, when you get time, but we there's some expense there that if there's any way we could share that expense with somebody else, it's going to help us in the long run. But
let me give you a few more stats here, Gene,
Okay.
that might make the expense seem more worthwhile. So 34% of healthcare organizations got hit by ransomware last year. That's a huge number. So every place you see that does healthcare, 34%, and this is from HHS. This is where I got this data from.
were they big hospitals or small? I mean, you given a percentage.
all over.
Was it one big one
This is
or-
a combination of all, so big and small. I don't have a breakdown of size. I mean, that could be
Okay.
pretty vast. The average cost for those attacks was 1.27 million. Some higher, some lower, but that's the average. Now we could supplement this. We could get insurance for this, which will cost us about $53,000, $54,000 a year. But it won't cover that $1.27 million for this ransomware attack. It would cover $750,000 of that. The problem with that is it also doesn't guarantee that the data that was stolen, or I'm sorry, I should say the data that was encrypted will be unencrypted. So if the data that was encrypted in a ransomware attack isn't decrypted, that data is lost, gone. And so let me find the stat here for that. Only 69% of the encrypted data was able to be restored. So if all the data was encrypted, we're still losing 31% of patient data, financial data. I mean, all of this very important data to us. Even if we had this insurance, even if we were able to repay this ransom, we still have a very real chance of losing a lot of data, which is expensive to our organization. And it makes a lot more sense to protect ourselves rather than to insure ourselves in this case, in my opinion, because insuring isn't going to be adequate based upon this data that we have here anyways. So it makes a lot more sense to take that money, boost our safeguards, boost our security measures that we have in place so that something like this doesn't happen. So what Sophos is quoting us, so how ransomware typically works, and just slow me down if I'm going too fast or anything like that. I'll happy to explain a little bit better. Ransomware is a file or a system that can sit on a PC, server, something in our organization. And what happens is that will sit there for a long period of time before that bad actor takes action. The reason for that is it will sit there so that it's part of our backup data. So that even if we were to say, oh my gosh, we're hit with ransomware, let's restore something that doesn't have this ransomware on it. When we restore that, the data is there. So it sits like on average 230 days, 270 days is what happens. It sits there completely undetected. What Sophos is promising, or their goal, I should say, is that they can detect that within 2 minutes. So that greatly mitigates our risk for something potentially that could affect the hospital in a very real way financially. To lose all that data would be very detrimental to us. So that's what this service provides. You asked if we reach out to UCLA. No, I don't reach out to UCLA.
Well, okay.
But we
I
do.
didn't-
But
I mean, anybody, even local.
well,
We
yeah,
have other
I
organizations
understand
like
dignity and the
CPSI
different
and others that we do talk to.
yes, CPSI is a company that handles EHR stuff. I reached out to hospitals that to see what they were doing in our local critical access hospital group for California. So I'm part of that. I participate in those calls, and so I reached out to some folks there to see what they were doing. We got some response back, and 2 of the responders actually are using Sophos for this. So there's lots of other companies that do it. As you can see in here, I have another quote for a company that's more expensive. They're very pleased with the results. They've had no incidents. The reporting is very good. And so, I mean, even outside of healthcare, like this is an important service to make sure that you have oversight on this 24/7 and with a team of experts that are able to help you respond in the event something happens. 34% is a very high number for a risk. So
The need, there's no question, the needs there. My question was, are we looking at every way to cover that need besides just buying it like the group that covers our liabilities that is together? Tim, what's the name of that group?
Well, like I said, this is $45,000, but it's for a 3-year contract, so it's $15,000 a year. So, which to me is very reasonable considering what they provide in the way of 24/7 coverage.
yeah, I
Versus
mean,
an
even
insurance policy that we may have to pay $50,000 a year on. And while there'll be some cash back, there's no ability to protect ourselves anymore from that. Again, their ability to find this very quickly would preclude us hopefully from being able to doing a backup after we've already been hit. That way our latest backup that we had obviously would still be good. So the faster we find that, the better our ability to recover from. So I think this is a great service from that perspective.
My computer's acting funny. Can you guys hear me?
you probably have ransomware, Gene. I have a service.
Okay. Catherine, are you okay with sending that to consent?
Yeah, because I remember him talking about it before. And for 3 years, I think that's
Yeah, for 3 years, but
good deal.
it's so much. It seems like there would be innovation and ways to change it or get the price down, but
I can tell you, Gene, that I worked extremely hard to get this quote to where it is. This is about $25,000 from where they started. We're actually adding another service in here for free that will help boost our email filtering to help us do that a little bit better as well. So they threw that in for free. And then if you look at this other quote for Arctic Wolf, just as an example, that's $65,000 for a very similar service, if not the same, for 1 year of service. And so we worked pretty hard to get this to where it is.
So that's the one you want, the one for 45.
That's the one I want.
Can you send it to consent, Heidi?
I could do that.
Okay. Now my computer, I can't see anybody. As long as you can hear me, that's all I guess it counts.
We can hear you and we can see you.
Okay. What's next on there then?
So Gene, before we move on, I think you're right on in terms of recognizing the proliferation of IT expenses for hospitals. Unfortunately, we're at the tip of the iceberg. It's going to get a lot more expensive than even what we're spending now. And we're looking at a couple major systems right now, one for HR and another one for the 340B program for the TPA software. All these things require a much higher sophistication to get us into the 21st century, to keep us protected, to really operate like a modern facility. So we've actually had the benefit from being behind the times financially, but at some point we have to make the upgrades and we have to spend the money.
Okay, okay.
And this is a budgeted item, correct?
Yeah, this is, I forget how much under budget it is, but it's if we were looking at the price I originally said, I think it would cost us per year. This is less than that per year.
Okay.
But it is
There's
an
4 zeros after the comma in the budget line.
what frustrates me is all these increased costs. When you ask the question, is Medicare and Medicaid paying us more on our rates? No, we're not getting a penny of any of this recouped in terms of acknowledging that the cost of information systems is going up as much as it is.
But it's also the cost of doing business, so.
It's the unfunded mandates, yes.
It is. I mean, this is not a mandate. This is just us doing our best job to make sure that we're protecting the organization because
It's a mandate that we stay safe.
Yeah.
Anyway,
Okay.
so I'll get off my
Okay.
soapbox.
Okay, the capital expenditure for the pharmacy.
Thanks, Carrie.
thanks, guys.
Tiffany,
Suda.
available or anyone?
Either
Hi,
Yeah.
Jean. Hello, Jean. It's Suda here. I know you can't see me, but I'm sure you can hear me.
Yes,
Yes,
Okay,
we can hear you.
good. Well, nice to meet you, Jean. It's the first time that we've met. So just want to introduce myself. I'm the pharmacist in charge at Mesa Clinical Pharmacy. I've been there for a few months now, so I wanted to put this forward. And I know we've been discussing this for a while in terms of getting a new software for the pharmacy, for the retail pharmacy. I think the one that we currently have, we've probably had it for about 30 years. And it's just not performing, and I'm quite surprised that the staff there have put up with it for so long. And I don't really want to go into too much of the problems that we're having, but just to put it simply, it's really inefficient. It doesn't do reports properly. There's no way that I can follow up with physicians. There's no way to follow up with refill requests. It's very outdated. And even though we had RX30 do some updates, and I'm constantly chasing them with tickets to try and improve certain aspects of it, but it's not working. And I'm spending too much time chasing an old system. It's really antiquated compared to the newer systems that are available. There's a lot of features in the newer systems that aren't available in RX30. Say if I want to bring in a delivery program in a few months' time, I don't have the confidence that RX30 would allow me to scale to those levels. We're thinking of bringing 340B in, and please tell me to slow down because sometimes I do get a bit carried away.
no, I personally, I see the need for it. It's been a need there for a while. So thank you for asking for it and putting it into use. But I think we should send it to the consent agenda. Catherine, what do you think?
I agree, because with the antiquated system, it's not good time
Right.
spending time chasing it. Yeah, it's
One
more work.
of the other concerns too that we have is our ability to track the revenue. Again, Suda can't even run reports on this thing that she needs to show us, how much money we've gotten paid on individual contracts, and are they paying to the contract and these kinds of things. So, I mean, that again, if we can get that ability, this will more than probably pay for itself as well. So, I mean, this is a 3-year contract for that price. So I think this is a desperately needed down there.
Yeah, it's a good deal.
And
Okay,
outside of the implementation costs, the cost for the actual month of service or however they're billing us is pretty much on par with RX30. And
Not
so
really that much.
okay. So it's no increase. Okay, Heidi, can you get down the consent agenda?
Will do.
Thank you. Thank you, Jean.
All right, so thank you. I think that was it, wasn't it?
Yes.
Yep.
Does anybody have any comments? They wanted to say anything except for giving me a hard time? Okay, then we're
No
adjourned.
comments.
Oh, I'm sorry, Catherine. Catherine,
Yes.
did you want to say anything or?
Not really. I don't have any comments. I guess since we're, I did want to bring up, I think that we had heard and being discussed yesterday was there something going to be done about the retail pharmacy and delivery, or
Well,
Was that-
yeah,
Couple
we're
things- couple things
we're gonna
we're-
talk about
I
that
was
later.
gonna Just tell Sue,
Okay.
give her a call after this.
okay, that's fine. I just didn't know
One-
if it was gonna,
Yeah, one was the pickup service there at the pharmacy to bring it out to the cars and so forth. And that's what I'm gonna chat with you about. And then the other student has a thought and a desire to put in a delivery system, which
Okay.
obviously would be much more beneficial to some of our seniors who don't have.
right.
Yeah.
And would there be a cost to putting those two items in service?
In terms of the digital with QS1, yes, we'd probably have to subscribe to their delivery platform, but then obviously we need someone to do the deliveries. But until we have the new system in, Catherine, I wouldn't want to push that forward until we have the new system in,
Okay,
because then it can track everything. It has a way where digitally the patient on the receiving end can sign for the actual prescription, and if they want to teleconsult there and then, they can reach out to the pharmacist. So there's all these features in the new system that we would onboard at that time. But delivery is something definitely, I think there's a lot of patients that can't come out that need that
Okay.
service.
I also have a meeting this afternoon with Kern Health Systems to talk about another vehicle and another driver that they're
Okay.
interested in providing for us. So
and that would help too.
you know,
And is that under a grant, Mark?
yes,
Okay, okay. And so the new system that we're looking at now will be able to complement anything that we have, whether it be like a iPad or something for them to sign when they receive their medications or consults? That's
Yes.
adequate for what we want to do. Okay, perfect. That's all my questions. Thank you.
Okay, all right. Then if that's it, meeting's adjourned.
Thank you,
Bye,
guys.
everybody. Thank you so much.
You're welcome. Thank you.
Bye.
Sue, do you